All right, let's do it. Oh, well, if you count our ambassador, we are at a 1-to-1 ratio. Thank you. All right. Well, we're going to go ahead and get started because it's 8 o'clock, and why not, right? So thank you, audience. We're going to today talk to you about HIV, Hep C, opioid use disorder, syndemic, and the ED, the impact of sex and gender. So we have an awesome panel today. I'm Lauren Walter. I'm from the University of Alabama at Birmingham. We also have Dr. Kiran Faryar from University Hospitals at Cleveland Medical Center, Phillip Moschella, am I saying that right, at Prisma Health, South Carolina, and Kelli Jarrell from the University of Cincinnati. And we all, here's our disclosures, and so this will tell you that we all come from places where we actively are engaged in hepatitis C, HIV, and OUD screening and engagement programs, which are supported by various funders. And so we hope to be able to bring our experiences from our own shops today to be able to provide some perspective, some insight, and hopefully some provocative questions about how we best practice in this arena. So just a quick to review our objectives and a little bit of introduction. So we've really gotten to a place in academic medicine where universal screening or targeted HIV screening and Hep C screening has really been around for a long time. We were talking yesterday, at least a decade, if not longer. I mean, more recently, they've been programs that are focused more on opioid use disorder, and the opioid epidemic have kind of joined these programs. And while each of these diseases, Hep C, HIV, opioid use disorder, in and of themselves does represent an epidemic, you really can't think about one these days without thinking about the other and the overlap in terms of risk factors and management. And so as we kind of increasingly expand the ED's role in this syndemic, we really need to start thinking about things from a precision medicine perspective, which is what the Consensus Conference was about this year, so precision medicine. And when we think about that, we start thinking about, hey guys, sex and gender. Come on in. So sex, which I'll talk about here, is to define, you just set some definitions. So sex, when we think about sex specifically, we think about the biological construct of sex. So typically chromosomes or hormones, we think about male and female. When we think about gender, that's more of a sociocultural construct. So that does not exist in a binary, but more of a spectrum. So masculine versus feminine are gender-related terms. And both sex and gender have pretty significant impacts on both health and wellness, and conversely also on HIV, Hep C, and opioid use disorder. And so as we kind of get into best practices surrounding HIV, Hep C, and OUD engagement from the ED, we're really at a point where we should really start considering each of these diseases from both a sex and a gender perspective, and how we might be most impactful in that way for our patients and patient-related outcomes. So with that, what we're going to do is we're going to talk about each of these disease processes individually, again from a case-based perspective, and then we're going to kind of wrap it all together and engage our audience in conversation at the end about what we're doing today, what we should be doing tomorrow to be most effective in this realm, again, specifically from a sex and gender perspective. So with that, Dr. Faryar, I'll invite you up to talk to us about HIV, please.
All right, good morning. Thank you for joining us on a Friday morning of the conference. So I wanted to start with a case presentation for a patient that came to our emergency department who was found to be HIV positive. So we can say Mr. KM is a 33-year-old male. In this particular example, the sex and gender aspect that we want to highlight is that he is a MSM, or a male who has sex with other males. As you can see here, this was kind of his chronology, and this was just starting in 2023. We didn't even go back to last year, but I think some trends that you can see are, obviously multiple ED visits, sometimes just a day or two apart. Other kind of things that we see very commonly left AMA. So the most concerning presentation was his presentation visit number 3, where he presented with an anal abscess. He was admitted, and they wanted to drain it in the OR, but there was a couple-day delay in him being able to go to the OR, and he wanted to leave. Despite, I saw multiple notes where they tried to talk to him, what was the concern? He still wanted to leave. And then, less than a week later, he came back, same concern, same medical concern. And this time he was, as of the time that I made this, he was still admitted, and I think the next box would be actually did leave AMA again. Prior to getting I think it was like the day after his surgery. Come on in. So again, this is not a chronology that's probably new to anybody. We have seen this before. So what are some of the social determinants of health issues for this gentleman? In looking at his notes and looking with the social work notes, both in the emergency department and inpatient, we saw there was a housing insecurity issue. So he does not actually have his own house. He's been living with other folks in the kind of February to March time. He was living with his cousin. Transportation, 3 of the 4 ED visits were by ambulance. 1 of the 4 was by private vehicle. So I don't know if transportation is an issue for him, and that's why he has a predominance of ambulance visits. And then prescriptions, he had been prescribed, started on HIV heart, and those prescriptions were at the pharmacy. He had not picked them up. It was a little unclear why, again, if it was transportation, financial, he wasn't interested in starting heart. Kind of unclear, but those were kind of the many layers of the social determinants that are also on top of the sex and gender identity barrier, good aspects of it. So just a reminder, this is from the CDC, but in 2019, gay and bisexual men still accounted for 70% of all HIV cases. Fortunately, the trend is going down. It looks like since 2016, numbers are going down, not at a rate that we are super excited about, but it is going down, so that's good. But they still do make up that predominance. And then breaking it down by ethnicity, African American and Black MSM still unfortunately have the largest number, make up the largest number of HIV positive cases, new cases with Hispanics, and then white males following after. So, this is still a population, I think, with all of the additional epidemics, pandemics, everything that we have faced, we just don't want to forget that this population still makes up a very large percentage of our new HIV diagnoses. So thinking about it from a provider perspective, things to ask about, and I think we probably all, again, had these conversations with our medical students, our residents, but we know it's really uncomfortable to ask about sexual risk factors. In our particular shop, I use community health workers, so they're certified community health workers who are our, patient navigators, linkage to care coordinators, whatever term we use. So they get a lot of training in, asking those kind of sensitive questions, but and doing it in a very non-judgmental way. So just objectively, do you have sex with men, women, or both? How many partners do you have? Like it says, vaginal sex, anal sex, or both. Is it receptive? And kind of explaining that, particularly if somebody's not too, super aware of that. Do you use condoms, yes or no? If so, how often? And kind of quantifying that to really determine their sexual risk, sexual history and sexual risk from there. And all of these questions are part of their assessment of patients for every single encounter. So it's really, as a way, and that really helps to normalize it, right? Like we're not pointing to just you or just you. Every single person that we approach, doesn't matter who, they all get asked these questions. So from the patient perspective, I think we can see, and we know there's a lot of distrust of the healthcare system by MSM and minority populations. A lot of it is, all you really need is one bad experience, right, with a provider, whether it be a physician, a nurse, whoever, who's not using the right language, who's not sensitive to these issues, not compassionate about this, for them to just kind of turn off, turn away from the healthcare system completely, which is, unfortunate, but reality. One of the things too, I think that may be a little bit more specific with this population is the use of social media. So our Cuyahoga County Board of Health actually started the social media campaign, the Test Me campaign, and they have like a Treat Me and then a prevention one with these flyers out, and they have this whole toolkit that we can use. I'm actually, of my community health workers, I've unofficially designated one of them as my social media person because I don't know how to tweet or TikTok or Insta or any of the things that you do. People of my age should be doing, but I don't. So I was like, you get to like, please download the toolkit, let's figure this out. But this hashtag text me. They also started this other campaign, Love Leads Here. We have fabulous t-shirts, but really making again, meeting that patient where they are. In this case, social media, right? A lot of these, MSM patients are on these social media networks, platforms, and that's where they get their medical content, that's where they get their news content. And so, I feel like our health department was actually very progressive in coming up with this toolkit, and we have, tried to use it as definitely to the not my ability, but my community health workers' ability to use it, and it's been really great. So I think that's just kind of thinking outside the box kind of idea, that this is how we reach those kind of different populations. And so with that, I'll turn it over to Dr. Moschella to talk about HCV. Thank you.
So to keep it going, another case-based, this is a patient that we're actively treating using our community I-Link program, which is using community paramedics to help deliver medications to folks in the community that really don't have any other resources. This patient, who we'll call TG, is a 50-year-old transgender female. Was formerly a patient of the VA, but hadn't seen any providers from the VA for many years, hadn't seen any providers for a long time. Basically had an MVC, and then about a month later came back with some pain and swelling to an extremity that was affected by the MVC. Was admitted at that point for a cellulitis versus bursitis versus abscess, depending on which service was commenting on the patient's infected joint. And was admitted and drained and was basically there. And while there, was able to engage with a program that we have in the emergency department where we use our certified peer support specialists, which are folks that are in active recovery that have been trained in motivational interviewing to try to help engage with patients. We have a generalized screening tool at triage, which non-judgmentally just asks, do you use any drugs? Like literally doesn't say illegal drugs, we took out the word illegal, they just basically say, have you used any of these substances in the last 12 months? Bling, 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 it just goes right down the list. And this person endorsed meth, and so they get a little flag on the track board, we call it the donut of truth, and one of our certified peer support specialists goes in and starts to engage with that person, and really tries to engage in a much more deeper and open conversation about substance use. And they're able to, I'm not going to use the word extract, but they're able to, reach the person on a different level that when I'm asking, it seems sometimes accusatory or that that they're going to be in trouble. But when our certified peer support specialists talk to them, they seem to really open up. He endorsed that he used IV meth and was tested as part of our opt-out screening program. It was found to be HIV negative, but HCV positive with a very high viral load, which was also nice for the surgery team when they went in there and they wanted to know about that. So interesting enough, while in the hospital, I would love to say our hospital is the most forward-thinking with trying to help with social determinants of health, but we are not. The patient was houseless, discharged with a prescription for antibiotics, which he couldn't afford, and was basically just sort of let out the door. And luckily, we knew about him and we're trying to get him linked in with some hepatitis treatment. And so we were able to use sort of some of our tools to try to help get him his antibiotics, get him linked to care instead of just here's a piece of paper, good luck, I'll see you later. As part of our CPSS program, we were able to link him with actual treatment. He is on treatment right now, and his SVR labs are supposed to come out, I think, next week we're supposed to go to. Our community paramedics program actually meets him where he lives. He lives basically behind, of all places, the Burger King. And so we actually meet him in the field behind the Burger King, and then we usually buy him food, and then sort of go from there. But this case is really meant to highlight that this is a veteran who has access to theoretically medical care, but has been very socially isolated because of their journey being a transgender in South Carolina. And I'm not trying to highlight South Carolina as this wholly, judgmental place. This happens across the country, and it is a phenomenon that we must embrace because we're trying to treat our patients, right? And TG is a patient just like any others. They have different social stressors and different things in their life which are otherwise making it sometimes difficult or impossible for them to either engage in care which they want to engage with or to receive care in a manner that we are currently designed to deliver, right? And so this is part of the issue here. And when people talk about sex and gender, it sometimes comes very loaded and people have very entrenched ideas. But at the same token, in the same way that you have a name and I address you by your name, shouldn't be any different by the same way you want me to address you by your gender, right? And there are manly men and there are heterosexual men and there are folks that are transgendering to what they feel more comfortable as and want to be identified as. And so we really do need to try to let go of some of those constructs that we've been engendered with while we've been growing up here and try to make sure that we are trying to reach patients and where they want to be reached. What I want to talk also is just about the overall predominance of HCV as it is here in the United States, because that's where most of us practice. It still has a bit more of a male versus female predominance. However, the incidence has been increasing outside of the birth cohort. This patient I presented was inside of the birth cohort technically, but technically what we're seeing here across the board here is that we have a rapidly rising increase in certain decades of life. So if you look here, the solid line at the bottom is those folks that are under 20, and then the top line there is our 20 to 30-year-olds, right? So look at that. That is literally like setting a trajectory to space. The increase has gone up almost 124% since about 2013. And that slope is somewhat replicated in our 30-year-olds, 40-year-olds a little flatter, 50-year-olds a little flatter, and our 60-year-olds are just above sort of where we are. So this is a predominance and a prevalence and an incidence that is increasing in our younger populations, which then again goes towards why the USPSTF and CDC have recommended now testing everybody, right? Is because it is not just the birth cohort, it's birth cohort plus. And there are special populations that I want you to be cognizant about for HCV, which have increased risk, which is some of our transgender females. There's a really nice meta-analysis that's done by this guy Murati, or person Murati, I don't know actually how they actually identify. And their group does a lot of meta-analysis on sex and gender and infectious disease and HIV, so their group has a lot of great papers on that. Most recently put one out in 2022 looking at the reported incidence or prevalence of HCV, HBV in transgender populations, both in Asia versus America versus worldwide versus Europe. So they kind of looked at all of those. Did basically a meta-analysis of what was done in various countries and or continents. The Dominican Republic has several studies, Spain, Portugal, and then several from the United States, as well as Asia, looking at places, China, and some other countries. The take home from this paper is that the transgender populations in the United States have double the rate of HBV and HCV infection compared to worldwide and those in Europe. And so there's more to go into about that, but I believe when you actually talk to a lot of these patients, they, depending on what region they're in and where it goes on and what social support, they may have no social support. Right? They may have very little access to medical care. They may be otherwise using IV drugs, selling IV drugs or drugs in general, and otherwise selling themselves for sex. Actually, my patient TG did open to us that they were selling themselves otherwise for sex and money and for drugs. And so their needle use may have been their portal of entry, but it also may have been otherwise sexual. So the reason I bring all these things up is to hopefully bring to light that the incidence of HCV is growing, that it is prevalent in various populations, and that some of our transgender populations may be more at risk for hepatitis C, and to try to keep an open mind when you're talking to these patients and realize that there may be things going on behind the scenes that you may not know about, but that you should engage with those patients and talk to them and try to offer the testing, because more than likely they may otherwise be positive. And to also talk about how trying to layer services may be a way for you to actually engage that patient in their overall care. Sometimes a patient getting a diagnosis of HIV or HCV and access to certain programs with Ryan White or other things may be actually that lifeline that does get them linked into the healthcare system. So with that, I'm going to turn it over to Dr. Kelli.
So good morning. Thank you guys for coming bright and early on Friday. So I'm going to start with a case that occurred at one of our community sites. And so I do want to point out that while our hospital system does have some of the same ED-based screening machinery embedded within it, at the time of this presentation and at the time of night that this patient came in, she came in between 2 and 3 in the morning, none of those resources were available at the community site. So it was just me and our nurses that were there. So this is a 30-year-old female patient who arrived with a chief complaint of psych evaluation in police custody. The police were called because she was sort of behaving erratically and running through the woods, and they were called to intercept her. On their interaction with her, they were concerned, both for her safety and also for her sort of mental state, and brought her to the emergency department instead of taking her to jail. On arrival, she was essentially agitated, erratic, ultimately was yelling at staff and trying to leave the emergency department before any medical workup was completed. So she received Versed and Haldol and then took a nap, during which time she was monitored and her vitals were essentially normal. After she had metabolized the Versed and Haldol, she was interviewed by our social worker, because it was then during the day when the social worker was there, who ultimately discovered that the patient was a survivor of human trafficking, had previously been in a safe house in a large urban city in many states away, and had been transferred to a safe house about 100 miles away from our hospital, essentially, in eastern Ohio, where she, during her time in that safe house, she had previously been in recovery from both opioid use disorder and also stimulant use disorder, and had relapsed and was re-trafficked by the persons from whom she was purchasing drugs. And she was ultimately fleeing from those people through the woods trying to get away when she was intercepted by the police. So during that interview, she became tearful. She was expressing feelings of worthlessness because her child was in the custody of her mother, and she said, "I just don't want to live anymore because I know I'm not going to be able to regain custody of my child because of all of these reasons." And so with that, I want to highlight some of the ways that opioid use disorder specifically interacts with sex and gender. So between 2007 and 2014, heroin use increased at a significantly faster rate among women, who also had a slower decline in prescription opioid misuse. Once opioid misuse is initiated, women tend to escalate more quickly to opioid use disorder than men do. Adolescent girls have a higher rate, of non-fatal opioid overdose than adolescent boys. And opioid overdose-related emergency department visits are on the rise among women, and women outpace men in terms of number of inpatient stays related to opioid use. Furthermore, women, especially highlighted by this case, women who have children specifically, but women in general, face significant barriers and disparities in ability to access treatment, and also in kind of motivation or perception that they are able to seek treatment. We've also touched on, and I'm not going to, I want to focus on this here, but my primary focus with this case is to highlight women who use opioids, but I do want to talk briefly about sexual and gender minority patients as well, because although we know a lot less about this group with opioids specifically, the risk for opioid use disorder is probably far greater than we realize, just because we essentially have minimal data. So sexual and gender minority patients tend to be prescribed opioids at higher rates than their sexual and gender majority counterparts. So one study from the Massachusetts Behavioral Risk Factor Surveillance System had 58% of respondents who identified as a sexual or gender minority between the ages of 35 and 40 had ever been prescribed opioids by a doctor, so more than half, compared to just a third of their counterparts who identified as a sexual and gender majority. Furthermore, as gender-affirming surgery becomes more available and transgender patients have more access, with opioids being sort of the mainstay of postoperative pain management, transgender patients are more likely to come in contact with opioids after being prescribed for postoperative pain management, as they're more able to access gender-affirming surgery. We really don't know a lot about opioid use specifically, but limited data suggests higher self-reported rates of opioid use, higher self-reported rates of substance use in general, and we also know that transgender patients and older patients with HIV have higher rates of chronic pain, and 1/5 of the patients in that group report being prescribed an opioid pain medication to treat their chronic pain. Furthermore, we have a lot of data to show that substance use sort of mitigates the relationship between life stress and sexual risk. So opioid use may compromise the ability to give consent. There's a relationship between condom use, injection drug use, and HIV screening. We also know that there are a lot of medication interactions that may impact our transgender patients specifically between opioids, hormone therapy, PrEP, and medication for treatments of HIV. Specifically, methadone and buprenorphine both have known interactions with antiretrovirals and hormone modulating medications, specifically spironolactone. So this may also impact, the ability of our transgender patients to access MOUD if they have been diagnosed and are interested in treatment for opioid use disorder. And finally, I want to bring it back around to the case. So this case highlights most of the social and structural ways that gender interacts with opioid use disorder, and specifically the way it impacts women who use drugs. So this patient had perhaps a rightful fear of legal repercussions, right? Especially given that she arrived to us in police custody. In this instance, it was overall, I would say, a positive interaction, given that the police were appropriately concerned for her well-being and brought her to the emergency department to ensure that she was dispositioned safely. But another study highlighted an example of a woman who was actually presented to the emergency department for opioid withdrawal and was arrested in the emergency department after her presentation. Ultimately, that patient was able to be linked to treatment through that experience, but she said in the study that if that had not happened, she would absolutely not have ever wanted to go to the emergency department again for fear that she would be essentially handed over to the police because of her decision to seek treatment. Fear of losing custody. Substance use is one of the most common reasons for out-of-home placement for children, and this is particularly true among low-income and racial and ethnic minority women. So in this case, that was essentially the key driver of our patient's negative expression of what was going on in her life. This key focus of hers was, I will never regain custody of my daughter. I will never get to be her mom again, right? And that was that also provides very unique barriers for females to seek treatment because there's so few options that provide childcare as part of it, both inpatient and outpatient. And so there's not only the practical limitation of what do I do with my kid while I go to treatment, but also the fear of my child will be taken away from me because I have chosen to seek treatment. Women make 70 cents on the dollar compared to men, so economic instability is a huge barrier for women to seek treatment. Single-parent households headed by females comprise the biggest portion of families below the poverty line, and women also have sometimes economic lanes that are closed to them, which forces them into industries, like sex work, where they are further exposed to psychological, sexual, and physical trauma. Women also experience housing insecurity in less visible ways than their male counterparts, as they are more likely to be able to find a shelter with a family member or with someone of their acquaintance. And so their sort of housing instability may be invisible to the providers taking care of them. We've talked a little bit about sex work. In this case, this patient was a victim of human trafficking and had been exposed to physical, sexual, and psychological trauma, both prior to entering the safe house in the other state and also subsequently after she was re-trafficked in just the few days leading up to prior to her ED visit, experienced all of this. Furthermore, one of the biggest barriers for women specifically who use drugs is the stigma and social marginalization. One of the studies that I read kind of characterized it as opioid use is viewed as incompatible with the role of women in society, both as caregivers and mothers. And so this is prevalent both in the healthcare system, in the treatment world, and it's very prevalent in women who use drugs feel that they cannot access treatment because they've already done something that's incompatible with their role in society. And I think that was really poignantly expressed by this patient, who was essentially like, I am so hopeless because I can never be a mother to my child, that I just don't want to live anymore. And so with that, I'll turn it back over to Dr. Walter to kind of close us out, and we'll have our discussion.
Thank you guys for sharing those cases, each of which were actual cases that they encountered in their shops, and hopefully illustrated pretty well not only the, again, the overlap of HIV, Hep C, opioid use disorder based upon, shared risk factors, but also kind of the specific sex and gender components of that. So what we'd like to do now, and I think maybe the best way to do this is just I'm going to throw some questions out to our panelists, and would encourage any of you in the audience, if you have questions or comments or anecdotes to kind of share about this. As we were kind of building this didactic and talking about it, we kind of came up with a lot of questions and barriers and things that we, in our shops, whether you have these programs or not, would like to work on to be more effective clinicians when it comes to engaging specifically from a sex and gender perspective on HIV, Hep C, and OUD. And so we kind of broke this down into like, what would we like to do from a administrative or clinical operations perspective to be more effective in this space? What can we do from a research perspective to be more effective in this space? And then a lot of us, we work with trainees, residents, medical students. What are we doing in that space to be more effective? So maybe I'll throw this out to our panelists first, and then of course anybody, questions or comments. So panelists, what are you doing, or what should we be doing from an administrative perspective or a clinical operations perspective to be more effective in this space, specifically from a sex and gender perspective?
Sure, I jumped on this one just because it's the most basic. So I think the first thing you always have to look at is if you have systematic testing in your shop and everything, great. If you don't, a lot of times the first hurdle is going to be like, what are the laws in my state? Like, what do I have to have as far as consent in order to be able to provide sort of screening? And it's not a mistake that opt-out screening is going to be the most effective. And the most effective is because when a patient comes into the emergency department or comes into the health system, it may not always be that immediately you're thinking of HIV or Hep C for that patient for their treatment of a broken leg or something else that's there. Now, it may absolutely be affecting their care, but it may not be the first thing that you're thinking of. Moreover, there still is, I know in my shop, still a sort of a taboo about trying to send an HIV and Hep C test, such that even in my own shop, where I have opt-out screening and multiple EDs, if that patient goes to one of the other EDs that doesn't have generalized opt-out screening within my own health system, they will not get an HIV test, even if they're coming in for treatment for an STI. I just published that paper, and I felt bad about it because it wounded my soul, but it was still there. And so it's still one of those things where it's sometimes there's multiple levels of barriers where people say, if I test, how am I going to get this person linked to care, right? And so it's just easier not to test, because if I don't see it, it isn't there. Okay, and that's really the biggest barrier. And that barrier is almost exponentially increased in our minority patients, or patients that are, say, transgender or anything. They're just like, I don't want to have to deal with the hassle. I hate to say it, but that's just what it is. So the issue is that what you want to do for admins or clinical ops is try to make it as systematic as possible, so it takes the decision making out of the equation, so people don't have to think about it. It's automatic. The reason why Roombas are in everybody's house now is because it's automatically vacuuming your house. You don't have to think about it. These things, it's in your head. It's okay. You want to have things try to be able to help you. The only problem with it is that you have to mold your EMR in order to try to work for you instead of against you. And sometimes that's hard depending on which EMR you use. And you have to have buy-in across the level, from lab to nursing to your operations people, and have a robust linkage to care system, because nothing's going to sink your program more is if you have this glut of patients that are positive and you have nowhere to send them. So don't be afraid to start small, right? Build up your referral infrastructure or your treatment infrastructure first. Have that ready and waiting, and then turn the go button and sort of sequentially start it up. Because if you have a shop with multiple EDs, start with one, then start to branch out to 2, 3, and 4, okay? Pick your level 1 trauma center, because that's going to have a lab that's running 24/7. Get the lab on board. Make sure they know that it's going to be adding on things into their lab. So there's just multiple levels that go in it, and the biggest hiccups have always been lab running the test on second and third shifts so that you get timely results, okay? So you have to get their buy-in on this. You have to get nursing staff to be okay with adding on tubes to their rainbow draw, or making sure that when they see those add-on labs that they're actually going to send it, okay? And you have to get your hospital on board and your hospital legal team on board sometimes with that opt-out screening, because not everybody's always going to be happy when they otherwise have opt-out screening and have mechanisms in place to help deal with folks that they want to opt out. So, does anyone have any questions on that, or sir?
So, I appreciate what you said about the EMR, but we see a large number of patients who don't disclose to us that they are HIV positive.
Sure.
And we end up going ahead and
Testing them.
because
Sure.
we have a provider and triage mechanism. Our BPA pops up. There's nothing in the chart that they're HIV positive to turn off the BPA, so we get to test it.
Yeah.
And, we do that, we get the positive result,
Yep.
we find out that maybe 30–35% of them are in treatment.
Sure.
So then that's a whole other conversation. Why are you telling us you're HIV positive?
Sure.
But then we find a whole bunch that are not in treatment anymore,
Yep.
never really went into treatment, and that have you found any good way to better identify those folks before?
I don't, and
Okay.
more specifically, the reason why they may not have disclosed, or the reason that is another reason to treat them as a new diagnosis anyway, right? Because it is a way for you to engage with that patient again to find out what's going on. Case in point, where I practice in South Carolina, one of the main treatment centers called 8 Upstate does not have a sign on the door. Their building is completely nondescript. And the reason they do that is because people were there trying to take pictures of people going in and out to get treatment. Okay? So I'm just putting it out there. I'm not trying to paint a big X around my state and everything else like that, but there's still stigma that exists, okay? It's getting better, but it's still there. So the reason with that is that I found also that I have the same thing as about 30 to 40% of my patients that we screen through the program end up saying, yeah, I knew I was positive, and then break down 50-50. Yeah, I'm in treatment in another county because I don't want anybody to know I'm getting treated here, or that I haven't been in treatment for a while. And so treating them like a new diagnosis, by the way, sometimes helps because they may have had a bad experience previously, and so being exposed to a better treatment algorithm now with a more robust linkage to care service and say, hey, we got you now, hey, let's get you started here today in the emergency department, thus works for those patients. So those patients have not wanted to re-engage because A, they feel like it's not a big problem, or they've not been able to keep up with it. And so when I expose them to a new system that we have in place now, then they're much more willing to actually stay in care, right?
Yeah, honestly, I think finding them again is a really great opportunity. And it's gotten to the point too that our county wants to, it used to be that we just would let them know about new positives. Now they're really wanting to know about known positives not in care, and just almost kind of like reset the clock, right? Like we just found out, we found out you're positive, you're positive, or maybe you don't, or you forgot, or, I think denial is also a really big component of this. So it kind of gives you that ability to reset and say, okay, let's start over, let's get you back into care. And our county wants to know that, and they're following up on them just as they would a new positive.
As far as
a lot of ours tell me at least that, oh, I was told I didn't have it anymore. And when
That's,
you
yeah.
Go back to later, it's the misunderstanding
Yes,
of the
yeah.
undetectable.
I've had many who think it's like a gonorrhea or chlamydia, and it's, kind of one and done. And so going to the education, I was the research in this education, but yeah, getting to that education and that, nope, this is a chronic disease, but very, manageable, all the spiel. But yeah, they think it's like gonorrhea, and it's.
I also have some patients that when we retest and we find again that are both relieved that they were quote unquote found again, and also help know, like, they were somewhat relieved also that they didn't have like the scarlet letter A that was following them per se. That Big Brother wasn't as deep into it. So I'm in a weird part of the country here where it's very much, I don't want everybody to know about what's going on in my life, but yet I need help with so it's sort of an interesting conundrum. But sometimes it's actually sort of helpful and be like, oh yes, thank you. I want to get reengaged. So I wouldn't take it out. It would be great if we had programs in place that as soon as somebody came in, we would know immediately, and then have to skip that step of having to try to retest and waste some of those resources. But I think that's a good investment, even just having that testing in there, and sort of go from there.
I think we had another question.
So my question is, sometimes these results don't come back in real time, right? It would be awesome if we just got everything in real time before patients leave. But patients leave, right? They get discharged, they have other things going on in their life. Have any of you all found a good way to get reliable contact information for any of these people? Because I think this is our biggest problem. We test a lot of people, and then we spend a lot of man hours trying to track people down because they've given us fake phone numbers or or we call them and you get a generic voicemail and then you're leaving a generic message because you can't be like, hey, you're HIV positive, you need to call me back, right? I mean, you have to say like, I'm calling from a hospital about results and then people are never calling back. I don't know if you guys.
It's a
No,
challenge.
I mean, it's a couple fold. So one, you definitely don't use the phone number or address that's in the EMR. You ask them. Thank you. Yeah, you don't use the phone number or address that's in the EMR. You ask them. We have found a little bit more success with asking about and not even phrasing it as emergency contacts, but is there another person in your life that you trust whose phone number you would give us? We will again not give any information to that person unless you consent to that, but someone else in your life that you trust that you could, we could reach out to if you need that. But
That's if it comes back at the same visit, right?
well, or it.
The
No, it's for
confirmatory
like that
testing.
follow-up. So it ours takes about 4 hours,
Yeah.
but if you have those contacts.
You can't ask them, you don't know that if you're screening.
Yeah.
So we ask anybody who gets tested gets those questions, literally before the blood draw is even
And
done.
so is that not your registration clerk though? That's
No,
your community
those are my
health
community
workers?
health
And then
workers,
where
yep.
are they documenting that number?
Red Cap.
Okay.
Yeah,
So like
so
an
we have-
external system.
Yeah. So I set up a Red Cap system that has many fields, and I added actually 2 or 3 fields for emergency contacts / people that you trust, and that's how they phrase it actually, and they found better results with that versus emergency contact because I think that's got again kind of some connotations to it versus like if you say it as a trust, it's someone in your life, and it could be a friend, a partner, whoever. And then they put that in Red Cap, and that's the system that they use to contact the patient again.
One place that we've expanded in the OUD space specifically, and I haven't done this with Hep C or HIV yet, but maybe we're creeping there, and you touched on this when you talked about HIV specifically, is kind of that social media space.
Yeah.
So we've started in our OUD patients specifically to start getting, okay, what's your Instagram, what's your Facebook handle, because we can Facebook message you that way. And so a lot of our patients will have, Wi-Fi only capable phones, and so they're not able to actually pick up an answer when we call them, but they'll respond to a Facebook message as soon as they get into a Wi-Fi area. And so that's something we're kind of navigating with our UAB social media and IRB stuff, but we have started to do that with our OUD patients, and I think once we demonstrate some efficacy there, it may creep into other, maybe it'll start becoming a routine question along with address, phone number, what's your Facebook handle, kind of thing, so that's something to consider.
Yeah. One thing, I was just going to comment. I mean, Caroline's problems are my problems because we work together. But one thing that is from the street medicine world is using Epic Chat back and forth with patients, which is sort of gets around some of the HIPAA compliance issues of social media. But with a Wi-Fi compliant phone, you can Epic message back and forth. And I heard from a street medicine program that they have one person that monitors an inbox pretty regularly, and patients will say, hey, come meet me at this place, or call me at this number. And so it's sort of a more real-time way to communicate with patients that gets around sort of the issues that you brought up of Wi-Fi enabled phones that maybe don't have service or don't have data, but they do have means to access something that is sort of more asynchronous.
You know what I think the next project is to get the registration clerks to get all this.
Good luck with that.
Hi, Phil. Good morning. The next project is to get the registration folks, because I mean, if you have community health workers, that's lovely, but that's not the majority of the shops in the world.
Our registration clerks are not up for that at all. They barely get,
No, right.
get consent for treatment. You know, they basically throw them a piece of paper. I get it. Sorry. Oh, sorry.
That, especially like the Hep C without with the intravenous drug use, those are hard to get.
Well, and the other, and there's fewer of them, and they're being asked to do more and more things. The clerks are, they're, like at our shop, they're actually being asked to, which is good, but asked to be, to schedule PCP appointments and specialty appointments. So if I say I'd like this patient to be seen by a PCP or a cardiologist in a week, they're being tasked with that, which is great. It's a very, it's very important task in and of itself, but to then ask, layer additional things on, it's very.
So we're trying to build it up. We're trying to build up our MyChart access through Epic a lot. We're really trying to push into that, which gets around all the HIPAA stuff. As long as they get somewhere on a phone that links into their chart, you can message through it. So we're really trying to take advantage of that, both on the positive and the negative side. So on the positive side, meaning if you're positive, we're trying to reach out to you through that. And really before discharge, that's the one thing, because our clerks have that, so this is adding workflow already in their thing. So if we just push the clerks, because our whole hospital is trying to get people to do MyChart more across the board, so we just make sure that saying like, even if they look like they might be homeless, you need to teach them how to access MyChart, right? Even if it looks like they can't, or they don't have a phone.
But sure, though, they will hard stop, move on.
That's right.
Next
So
patient.
that's the biggest thing. And I say, you are supposed to do this from your job, from the hospital standpoint, so do this, right? Because if I'm adding on stuff for like getting extra information or extra phone numbers, they're not going to do it. But I say, look, you're already on the dime trying to make sure that you have to get everybody on MyChart, whether they own the building, live under the building, live next to the building. Do that, right? And so then we're trying to make sure that that works and making it as part of the thing. Because if you add on work to them, they're just going to shut down and they don't
You
care.
do have
No,
other-
I was going to say, I think the registration clerks are seen as the bill collectors. So I think that's why patients
That's-
are very
yes.
reluctant
Yes.
to give that
Yeah.
information.
Your
'cause it-
copay is
Right,
$50
and then
today.
they know that when they get the final bill, they're not going to get paid or be able to pay it, so they don't want a way to be contacted. So
Yeah.
we'll often have the conversation with them separately that this number is only for healthcare, and whether I stick it in my note or into our database, and this way we could call them. And I just wanted to add, I know you didn't get to the other two yet, but have you thought of adding syphilis testing to your program? Given
do, yes.
Yes.
epidemics,
It
maybe.
reflexes- it reflexes for us. We should be doing, technically, we have such a problem with syphilis in South Carolina right now that technically we should flip-flop it and start screening everybody for syphilis and work down that way. But a lot of times it reflexes the other way.
Yeah.
Um,
We don't have an opt-out, but we have a risk-targeted screening approach, and it's in our STI order set. We use a reverse algorithm, but it's part of our process.
Yeah, all of our stuff reflexes from, say, gonorrhea, chlamydia, and you're positive, boom, automatically flips over. And then also from HIV, Hep C, boom, it flips over and adds it on.
Yeah.
So.
Real quick, just to touch on, and I think Dr. Waxman brought up, a study on registration. So just to pivot a little bit to the research side, if we're thinking of the, keep it simple, stupid kind of ideas, things that you can do that would be very simple in your research planning and in your studies that would address the sex and gender identity concerns is honestly just having those check boxes, right? Instead of when you look at the demographics, not just male and female, your transgender, non-binary, do not wish to disclose. I think that also needs to always be a category. So just having that box, and I think once we start seeing more and more articles with those categories, we'll start to see that that's the new norm, right? And we see it with race and ethnicity. Yes, ma'am.
Yeah, just because everybody in this group is very interested in sex and gender.
Just to try to keep it, they're recording it.
Hello.
Because everybody in this group is interested in sex and gender, I just want to share a paper that came out in the last couple months that really was put out by either the National Science Academy or NIH to try to get us all to use the same definitions for demographics. So I think it's just a really helpful paper. It's called Measuring Sex, Gender Identity, and Sexual Orientation. And it's a better way to make sure that we're all using the same language.
Yeah, no, I think that's a great point. And again, you will likely have to take that, additional step, because it won't be in your EMR, right? That's not a checkbox in your EMR. And so if you have various different reasons. I mean, I think Epic has moved to that. They have the SOGI questions, right? The sexual, gender, I don't know what the O is, identity questions.
They also have, I think it's called like an organ inventory, which is very helpful medically speaking. It's like which organs do you have, what do you how do you identify what was your sex assigned at birth, but also, do you have a prostate? Do you have a uterus? So it's exceedingly helpful, but it's very challenging to complete. And so we had, like a lecture from a primary care provider who has only transgender patients in her practice. And she's like, oh yeah, I just have a nurse and an MA and this works perfectly for us. And I'm like, because everybody is caring about this patient population. In the ED, our registration folks cannot complete it. And it is in the registration piece. It's just very taxing. So it's really nice if you can get it to work, but it's really hard for all the reasons we've talked about. It's like the registration folks don't have time, we can't access it, and the nurses, I think, maybe can variably access it, but it's not in their workflow.
Kelli, do you want to close this out with a quick comment for education?
Sure. I picked education because that's what I do. I don't have the research chops of these folks, but I'll just sort of summarize what I think is the key tenet of doing education well about this. If your hospital has a functional screening program, it is often invisible, specifically to your trainees. And so a lot of our residents take for granted the resources that they have because they're so integrated into our emergency department. So actually being like, this is the screening program that we have. This is how many years it took to build it. These are the patients they screen. This is why they screen these patients. These are the disparities as they exist in our city and in the world, and making that, which should be invisible to them if it's functioning well, making it apparent. This is the work that went into it. This is the reason why we do that. This is why it's integrated into our health system, to make it invisible to you, because you have enough to do, right? We are making this happen for you. This will not happen many other places that you go, and sort of removing that sort of like the Wizard of Oz man behind the curtain and showing what's behind the curtain is, at least from what I have seen, being a resident at our shop and now faculty at our shop, very useful in terms of educating residents and removing the sort of opacity of the disparities that exist in our city.
I think as far as the transgender too, as far as reaching out to a patient directly, I think you only need one patient that you come to them and say, hey, what gender pronouns do you want me to use for you today? And you see them relax and they're less guarded and they say, thank you, yes, please refer to me as this. And then that opens up a whole nother level to that encounter where that patient was otherwise very guarded or something like that. That they just need one or two wins like that to make it part of their normal lexicon to go up and be like, hey, how are you doing? I'm Phillip, I'm your doctor today. My gender pronouns are he, him, and his, and it just becomes rote. And so it just makes it so much easier to then engage with that patient. And I just wanted to focus just a little bit on the transgenders to bring it back a little bit, just because this is something that is still new and we're still dealing with how to best engage with these patients. And that right there just opens the door. If you get one or two wins where that physician, and some of our older physicians too, saying like, look, this is easy, right? And it just makes your life easier when you talk to the patient.
I think with July coming up, I think there's, in addition to letting the trainees know, I have 15 minutes in our new physician onboarding day, where we are talking about all the ancillary services. We have social work, we have, SANE, and then I talk about the community health workers that I have and what they do to let all the new attendings and fellows that are coming in know about this, because like you said, it is very invisible, and that's part of the education. This is something that we have, and I want it to be a bi-directional flow. Like, I want the community health workers go up to the providers saying, do you have any patients that you'd like me to specifically talk to? And now, after probably about 3 to 4 months, the providers are now going up to the CHW saying, can you go see this patient, that patient? So just literally just getting in front of them at orientation, and with the new round of residents coming in, getting in front of them for 10, 15 minutes to let them know this program exists.
Yeah, just to follow up on that too, one thing that I have seen at our shop is sort of having a face to be in front of all of your different layers. So like talking to the nurses, talking to the social workers, because at least what we have seen is some of our folks, if they are going to for example, at the community shop where I work most, when our EIP folks are trying to go up there, the social workers are territorial. We're already doing this well, we don't need your help. And so having like being a face to say like, no, this is how we can help you, this is how this team will function better with all of the parts working together, I think is super helpful. And that involves your entire care team from, I know we've been kind of wailing on registration, but registration, nurses, PCAs, social workers, and your trainees and your faculty.
And your ops people will say, hey, there's no time to have that in their care. It's going to slow down and increase throughput time and stuff. It does not. Having our CPSSs or community health workers, there is dead time built into every ED encounter, and having somebody else talking to the patient just increases their satisfaction. So we've seen our satisfaction scores go up with the peer support specialist in our emergency department. We've seen our turnaround time actually go down for our substance abuse patients because they're able to be turned around even a little bit more faster because the CPSS can say, hey, they're willing to engage in care, we got them a bed here, I'm gonna see them tomorrow, and so they're able to be discharged even faster than they were before. So don't let your ED ops people say this is gonna slow stuff down. No, adding resources to the emergency department speeds things up no matter what it is.
Well, thank you. We are out of time. Thank you to our panelists. Obviously, lots of rich content. If you want to continue the discussion, please feel free to reach out to any of us. There's a lot happening in this field. So thank you so much for being here early.
Sorry, quick announcement for anyone who's interested in this stuff. There's a SAM, I'm shameless, SAM interest group called MTIDE. We're meeting at 10 o'clock in an hour in room 213. All are welcome. Very much like to see everyone there. We've talked